So here I am with Sam Campbell, who's my boss, and he's also a great educator and Airway aficionado. And often he also has an office about two doors down from me. So when I finish a shift and I have a tough case, I often wander in his office and say, "Oh my God, I had this case." On the other hand, he's also the guy who comes in and says, in my office, says, "George, remember that patient you saw the other day?" And that happens, unfortunately, more often than what I want. But what I want to do is just to throw out a case. He has no idea about what this is, and see how Sam would manage it. And this is a case I had the other day, and this was a 74-year-old gentleman who actually was a foreign language speaking gentleman. I won't say what language. I couldn't speak that language, and he presented with massive epistaxis, and he must have aspirated, because when he came in, his SATs were 84.5%. And I said, "I got this. I can take care of this." So I said, I'm going to have to oxygenate. I've got to do, all those things to optimize that patient before I go on and intubate this patient. So I knew as Rich Leviton said, I just have to, sit them up, pull on the mandible and blow O's up their nose. And then I realized, geez, he's already sitting up. I can't blow O's up his nose. And, he doesn't like it when I pull on his mandible. And his SATs are 85%. I didn't know what to do.
It's very important with these patients to realize that quite often they swallow a lot of blood, and the blood can be very irritating to the stomach. Okay, and they can just make them very uncomfortable. So before you worry about the airway, it's important to do a thoracotomy and grab hold of the esophagus and just don't have to push very hard, but just enough to stop that blood from getting into the stomach, because it can be very irritating.
Right.
Now,
so instead of doing, cricoid pressure, which people know really isn't very effective.
Oh no, it pushes to the side. You want to get in.
Right. So if you've got a thoracotomy, you can identify the esophagus, and then. Well,
the other thing about the thoracotomy is once you've got the esophagus, you're actually very close to the trachea.
Right.
So you could actually do a retrotracheal. So if you get a guide wire, and it doesn't have to be. It doesn't strictly have to be sterile, but if you can thread a guide wire upward, quite often you'll hit the crina and it'll come straight out into the mouth.
So what do you do then?
Well, if he's still bleeding, you see, by now a lot of the blood from the esophagus is actually running down the trachea. So I do try and get like a pediatric feeding tube and put that on suction to try and clear some of that blood. But then if you push really hard with a wire, eventually it stops, and then that it's least in the base of the skull.
So let me just stop there for a second, because I know that we've been moving towards doing an awake crike, and I get that because we can use local, but we haven't intubated this patient. I'm just wondering how we should take care of the awake thoracotomy. How much local do you need to do that, and do you worry about lidocaine toxicity in that situation?
Yeah, no, I use a lot of spray. You got to spray really hard as well.
On the skin.
Well, kind of on the skin, around the skin. In the air is pretty good. In fact, you can get these vaporizers that'll do the whole room pretty effectively.
In the sprinkler system too.
Well, that's the other one. So if you have it's actually lidocaine without epinephrine in our sprinkler system, because there are issues with sort of safety codes and that. But if you can get, obviously, you need to smoke at times like this. These are stressful times. So usually I'll have a bit of a joint. It's Nova Scotia, but if I was down south,
we have Trudeau now, so that's going to be.
Yeah. So if you're gonna be having a joint at this stage, it's really reasonable. You got the lighter, just lean up, switch on, stick on.
So that's how to turn on the lidocaine and stuff. Yeah. So let's get back to the awake thoracotomy as part of airway management. Now we're moving forward. In fact, I was talking to Sam recently about whether he'd be able to fund a trip, because airway management is not just about endotracheal tubes now. We're putting tubes in different places to do airway management, so ED ECMO. So what I was thinking about doing is doing ED ECMO, and then I had to remember what ECMO stood for, and
well, it's enema, constipation, management, and outcomes. So you really want to get shit out of this. I mean, to be crude,
Yeah.
a constipated patient is very
Yes.
difficult to intubate,
Yeah.
especially if
Yeah.
they're very constipated. You've got your hand on their esophagus. There's lidocaine raining down from the roof.
Yes.
Very difficult to keep the joint aligned. Nipple caps, very uncomfortable in times like this. So you've got your nipple
So
caps.
you know that we're going to be on probably YouTube or something like this. So we're going to have to be careful about some of the discussion here, and this is rated whatever the bad rating is. So we're going to stop, and I'm going to pretend I cut out that section about the caps and stuff. But where were we? We were talking about ECMO.
Well, we were talking about
constipation
nipple caps, but you
and
said
stuff
I
like
had to
that.
stop. Yeah.
So, and that's sort of the equivalent of the patient who comes in with a full stomach. Ultimately, that's the worst of constipation. So, that they've got a bowel obstruction. As this patient did, I forgot to mention that, and they probably had the bowel obstruction because of the massive epistaxis that was going down, and it's sort of had this big clot that sort of usually gets stuck in the jejunum. In the distal third part around the corner there, and that's why they could have been vomiting. And
just to keep this generic, if your institution is one with an iron lung, and you can get an iron lung that is actually larger than the patient, that can actually, the negative pressure of the iron lung can suck blood that would have been in the esophagus into the trachea where it can be sucked out, but it also helps with the ECMO, so that constipation is sucked out at the same time. It's not as comfortable for the patient because eventually the iron lung obviously fills up.
So let's get back to Jim DeCanto, who's a great guy, anesthetist, educator, energetic guy, and he's got this salad machine. Look it up, which essentially it doesn't make salad actually. So it stands for something that I can't remember right now, but it has nothing to do with edible salads. It has to do with managing. It's a model to teach you how to manage copious amounts of vomit. And how to approach the airway with that. Now he uses sort of this green fluorescence there instead of, and we use the red blood in our patients, right?
But if you do have
a
salad, green fluorescent salad, you're likely to vomit.
So he talks about using the suction with whether you leave the endotracheal tube. Now let's say you decided to go on to intubate this patient, and you went in, it just was welling up, with all the red blood.
Green salad.
No, this is red stuff now.
Okay.
And you're suctioning, and you got two suctions going, and it's not, but you say, I think I see the airway and stuff, and you put the tube down, and now there's blood coming out of the tube, right?
Itself.
Where do you direct that tube?
Now you don't have any salad.
No, there's no salad here. Just the red blood coming out the endotracheal tube. It's probably because there's red blood coming in. It's actually not going. It's probably in the wrong place in the esophagus, and we haven't done a thoracotomy yet here.
Okay, that's before that, and no salad.
No salad.
No kebabs.
No kebabs.
Lidocaine.
We ran out. In fact, the sprinkler system's down for maintenance.
Okay, so the tube has got blood coming out of it.
Yes.
So it's really important to do something with that blood.
Yes.
Now, you're familiar with the work of Jackson Pollock?
Yes.
So you can do a lot of spatter stuff with blood. Now, the nurses don't like this, but sometimes you can make the nurses look really funny. I mean, between you and me, if you spray as it
comes out.
It can be very interesting.
So getting back to patient care is that I know you're
I care
a man
about
of the
patients.
arts, and I understand that,
patients,
and
salads,
and salads, but do you leave that tube in and try to put another tube in? In other words, direct that to a junior medical student.
Oh, you know what? I've never done it, but I've heard. You know what Chinese dolls are? You get a doll, you take one inside. So you can
Those
start with a side Russian doll.
Russian dolls.
Yeah, they're made in China, but they're sold in Russia.
Yes.
So if you start with a say size 9 tube, which is bigger than most of us have, you could probably fit a size 7 tube in that, size 5 tube in that, and you can keep doing that, and less blood comes out each time.
Yes.
And
You're causing sort of a tamponade kind of effect.
Yes, and also you
Yeah.
store the tubes as well. You
Yes.
can put a lot of tubes in one space.
Yeah. So if you need one, a smaller
and
size.
when they
you
say,
can-
did you intubate the patient, you say several times.
Yeah.
So, in terms of your success
Now,
rate,
would you-
so if you have a 50% success rate, and then the next patient you intubate 7 times, you actually have a 120% success rate, which is better than most people can actually boast.
Right. Okay. So what I was wanted to do is try to put this all together, because we've obviously talked about some fairly high level technical stuff, and if we were to sort of simplify this and for everybody, and I use sort of a grade 8 level of for myself, if I want to understand the stuff on the interweb and the PubMed and all those article things and stuff. I've got to explain it down to my grade 8 level, and you're great at metaphors. And if you were to put this all together in a metaphor that would resonate with us and let us think about our approach to massive epistaxis and salads, and how would you what sort of metaphor would you?
It's like if you were on the back of an elephant going through the jungle, and you were looking for a particular type of tiger, you don't look for the one that hasn't got stripes.
Right.
So I think that kind of explains the whole thing.
Yeah. I couldn't have said it, in any other way. And as you can see, this is why, he's the boss, and I'm not worthy. You've heard it here.
You're not worthy, but that's okay.
Yeah.
Because someone has to make the salad. I mean, salad doesn't just
That's true.
appear. Okay.
That's true. Okay, well, see you later. You heard it here first. Sam Campbell, he's the man.